Good evening, everyone. Today's topic for discussion is anorectal malformations, follow-up, and long-term issues. Myself, Dr. Vinay Kumar Terdal, and moderator is Dr. Murali sir. So, coming to postoperatively, uh, we begin dilatation after 2 weeks of surgery, and anus is calibrated dilator that fits snugly, used twice a day. The every week size of the dilator is increased by 1 unit and until the desired size is reached. Once the correct size is reached, the colostomy can be closed. Usually, it takes 2 to 3 months after reconstruction. The dilatation must continue after the closure also. Once the dilator can be inserted easily, the schedule is reduced to once a day for 1 month, twice a week for 1 month, once a week for 1 month, and then once a week for 3 months, then stop dilatation. Post-colostomy closure. Post-colostomy closure, they may have multiple bowel movements and perineal excoriation. So at this time, the constipating diet may be helpful. So after several weeks, the number of bowel movements decreases. So at this time, most patients will essentially become constipated and must be anticipated and proactively treated. After 3 to 6 months, there will be more regular bowel movements pattern develop. So patients with 1 to 3 bowel movements per day, they remain clean between the bowel movements. So they shows evidence of feeling of pushing during the bowel movements. So this type of patients, they have a good bowel movement pattern. They usually have good prognosis and they are toilet trainable. The patients with multiple bowel movements are those who passes stool constantly without showing any signs of sensation or pushing. So these people typically has a poor functional prognosis for bowel control. So this type of malformation, the quality of sacrum and spine, they predict the potential for voluntary bowel movements. Coming to long-term issues, the assessment of long-term results, functional assessment done when the child is toilet trained, that is usually after 3 years. The long-term problems are like the functional psychological problems such as fecal incontinence, soiling, constipation, and urological, sexual, or psychosocial issues. The normal fecal incontinence. What is normal fecal incontinence? So the producing feces once or twice a day of normal consistency at a proper time and place without soiling in between and without taking dietary measures like and anal aids or medicines. The constipation is passing stools fewer than 3 times per day per week or straining at stools for more than 25% of the time. So in case of incontinence, according to Kieswetter and Chang, uh, the good control is the continent. Most of the time, there will be occasional soiling during diarrhea or any physical stress. The fair control is the occasional soiling with normal stool consistency but acceptable social continence. In case of frank incontinence or permanent colostomy, it is called as poor result. So patients with high or intermediate malformations were more likely to have difficulty sensing the impending stool and they hold it back. So the constipation is most common sequelae following lower the malformation. So more likely there will be development of the constipation. So the vicious cycle ensues with megarectosigmoid which leading to more constipation. The constipation that is not properly managed will lead to the more megarectosigmoid resulting in overflow incontinence. So these patients should be uh, uh, treated for constipation, then they will become continent. So sometimes they benefit from sigmoid resection to reduce their laxative requirement, but which is very rare. Coming to physical growth and development, the impaired growth and development when associated with one or more comorbidities. So there will be mental growth as normal populations. The around 10% have motor developmental delay. The maximal exercise tolerance was slightly but significantly lower than in the normative population. The growth impairment not related to the type of malformation, whether it is a low or high, but it is related to the comorbidities like involvement of the urogenital origin. Coming to urinary tract problems, The urinary tract malformations are seen in around of 40% of the anorectal malformations. The late surgery to repair concomitant urogenital anomalies are seen in around 20% cases. The significant risk of death from renal failure is around high in case of high anomalies around 6.4%, and the in the low anomalies it is around 1.1%. So the urological problems are the neurogenic lower urinary tract dysfunctions like vesicouretic reflex, urinary incontinence, neurogenic bladder, recurrent urinary tract infections, or impaired renal function. The impaired genitourinary innervation causes ejaculatory or erectile dysfunction. Coming to most common urological problem, that is a vesicouretic reflex that is seen in around 18% of the cases of anorectal malformation. There is an increasing incidence with increasing severity of uh, anorectal malformation. These most of the cases are treated with conservative approach. They rarely need surgical intervention. So, ultrasound is advised when there is a upper tract dilatation or recurrent urinary tract infections. So, followed by MCU. The voiding dysfunction usually is neuropathic in origin, commonly caused by associated defects of lumbosacral spine, like sacral agenesis, or abnormalities in spinal cord, like tethered spinal cord. So, the less commonly, the iatrogenic pelvic nerve damage during reconstruction occurs. So, the urinary incontinence may improve with bowel management, or they require CAC when secondary to neurogenic bladder. So these cases rarely require procedures for bowel management. The perform urodynamic studies as early as possible in case of sacral agenesis. This is to assess and define the type of lower urinary tract dysfunction and to start the appropriate treatment regimen with the bladder dysfunction. Coming to psychosocial problems, it's an important goal to management in ARM cases is the preservation of sexual and urological function. There is a close relationship between the psychosocial development, the continence, urological function, and sexual activity. Coming to genital anomalies, uh, around 26% of the males will be having, in case of anorectal malformation, will have undescended testes and hypospadias. In around 5% of the females, they will have vaginal and uterine septations anomalies and vaginal agenesis. Coming to sexual problems and fertility, the pelvic floor surgeries like abdominoperineal or sacroabdominoperineal repairs, which used to do earlier cases in earlier times, and hypoplastic pelvic floor and urogenital comorbidities will have more sexual problems. So the erectile dysfunction and ejaculatory duct obstruction, retrograde ejaculations, or sexual distress are seen in case of males. The sexual distress, dyspernia, or Mullerian structure agencies are seen in females. Post PSRP, there is not much reduction in erectile dysfunction or sexual functioning, but only a delay in becoming sexually active compared to other pairs. In case of female ARM, the dyspareunia is seen in around 60% of the cases with vestibular fistula or cloacal malformations. This may be caused by scarring of vagina during correction of the rectovestibular fistula or of vaginal septum. The causes of impaired sexual functioning are difficult to assess, but some studies have looked at depression and self-esteem and body dissatisfaction. The vaginal deliveries and pregnancies may also worsen fecal continence. The inability to be happy with yourself, or the inability to have a relationship with peers during adolescence are the factors that can be a cause for problems in sexual functioning in later life. So the sexual education is during the follow-up is a very essential element. Coming to social quality of life for adult patients. So around one third of the patients with high or intermediate type anomalies occasionally complained of fecal swelling that disturb occupational life. But other two-thirds of the patients or those with low type anomalies gained good bowel function and enjoyed their social activity. So some patients may avoid sexual contact because of defective fecal continence. Coming to vertebral anomalies and myelodysplasia. The vertebral anomalies, they rarely require spinal bracing and spinal stabilization. The spinal abnormalities like tethered cord, spinal dysraphism, they require intervention because of progressive neurological symptoms. There is no evidence of prophylactic detethering if there is no symptoms. Coming to cardiac anomalies, the incidence of anorectal malformation is around uh, cardiac anomalies in anorectal malformation is around 22%. VSD is the most frequent cardiac anomaly, but in India, ASD is the most common cardiac anomalies, followed by PDA and tetralogy of Fallot. Most congenital heart diseases, they do not require immediate intervention. They can be delayed until the correction of anorectal malformation. But few cardiac anomalies are complex. They need some medications like prostaglandin in ductal dependent lesions. The transposition of great vessels may need palliative procedures such as atrial septostomy to improve atrial blood mixing. They should be dealt with before ARM repair. Coming to syndromes in anorectal malformations, the trisomy 18, 21 bacterial anomalies are the few syndromes associated with anorectal malformations. The overall prognosis and quality of life depend on the severity of associated anomalies. There is a high index of there should be a high index of suspicion, and meticulous evaluation should be done to promptly detect the coexisting anomalies is very essential. Coming to functional outcome following secondary surgery for ARM. The secondary reconstructions to improve uh, poor anorectal functions have been used extensively in patients with anorectal malformations, but the long-term outcomes is not better in patients who have had secondary surgeries. The few reconstructive surgeries like graciloplasty, which is a common method for secondary sphincter reconstruction, or levatroplasty, which creates an acute anorectal angle. So there will be actual resting or squeeze pressure. They do not change at anal canal level. So the long-term results are not encouraging in these cases. The rerouting of pulled through bowel. In case of uh, abdominoperineal or sacroperineal pull through, there will be displacement. The neo-anus will be kept more anterior, so there will be high chances of this continence problem. So the misplaced anal canal following primary operation will be there. So rerouting of this pull through bowel can be done later, but even this surgery has not much encouraging in long term. The secondary PSRP for fecal incontinence also there is not much encouraging results. Postoperative treatment, multidisciplinary behavioral treatment, the defecation problems. The constipation disappears in adolescents and fecal incontinence also improves. The chronic defecation problems like which causes negative impact, somatic and psychosocial development, which leads to eating problems, chronic fatigue, inactivity, and urinary problems. The incontinence, which causes social and emotional problems, which has negative self-image, lack of self-confidence, and behavioral difficulties and parent-child interaction problems. So avoid unpleasant or painful rectal interventions in ARM cases. Start behavioral treatment if the child is still incontinent at the age of 4 years. That is even after toilet training period. So in case of severe constipation or failed medical therapy or dietary therapy, behavioral treatment can be started in an earlier age also. Coming to multidisciplinary behavioral treatment, the rectal filling causes sense of urge, which induces defecation reflex and empty the bowel. But in continent children, there will be interaction between the organ and the behavior of the child. So the child has to perceive a sense of urge and learn to react by withholding the defecation for a short while and go to toilet for voluntary evacuation. But in this process, the several things can go wrong. So the pain with when there is a pain with the defecation, the child will react to sense of urge by withholding instead of relaxation. So there will be incomplete defecation which causes constipation. So the children who are constipated for a long time, there is they don't no longer feel any sense of urge. So will not do anything to have a defecation. So there will be persistence of the problems. So it is common in children with anorectal malformations who are already more vulnerable for constipation. So the multidisciplinary treatment will be the parents are counseled regarding the disease prognosis, associated anomalies, and their effect on long-term outcome. The parents are used as co-therapists. The aim is to teach the child bowel self-control, training defecation skills, and toilet behavior. The team consists of pediatric surgeon, child psychologist, and pediatric psychophysiotherapist. The role of pediatric surgeon is to facilitate the learning process by prescribing a oral medication to allow sufficient emptying of the bowel. The oral laxatives prevents new impaction and continue till he masters enough self-control. The role of child psychologist is to educate the child and parents to establish the problems. To lack of knowledge, defecation, anxiety, motivational problems should be managed. The parental skills cooperation are investigated and they are attended. The role of pediatric physiotherapist is to assist managing learning process by motor games. The child is taught to evacuate the feces voluntarily even without a feeling of urge by teaching a correct straining technique, that is by building up a pressure in a right direction and to tense abdominal wall muscles and relax muscles of pelvic floor selectively. So the treatment can be given either by individual or in a group. The group treatment is very effective for both parents and kids. So start with behavioral treatment in case of constipation. When it is not effective enough because of the anatomical limitation or psychiatric comorbidities, or there may be because of parent to child interaction problems. So in that time start bowel management. Thank you, sir.